Very good evening to all of you. I would like to welcome all of you to the Uromet 3. This is the fifth session, and I would like to warmly welcome our expert panel, Dr. Yasiru and Dr. Srinath. And there are other two members to be joined yet. So first speaker is Dr. V. Sanjeev. He will be talk about core knowledge of penile cancer and pre-malignant lesions, penile intraepithelial neoplasia and its management. Dr. Sanjeev, over to you.
Good evening, everyone. Can you see my presentation?
Not yet, Sanjeev.
Okay. Oh, yes. Now, sir?
Yes.
I'm Dr. Sanjeev. My topic is penile cancer. I will be concentrating more on the core knowledge of penile cancer and then management of penile intraepithelial neoplasia. Penile cancer is a rare cancer. Incidence varies across the world. Mean incidence is 0.8 per 100,000 population, and it is more prevalent in South America and Southeast Asia and certain part of Africa. Peak age of diagnosis is 6 decades, and the incidence is rising in the West due to higher infection rates of human papilloma virus. Risk factors mainly phimosis and chronic penile inflammation, as well as HPV infection, especially with the 16, 18, 31, and 33 variants, multiple sexual partners and early age of sexual debut, lichen sclerosis, smoking, and ultraviolet A phototherapy, which is usually used in psoriasis management, and low socioeconomic status. Pathologically, 95% of penile cancers are squamous cell cancers, but there are rare type of primary penile cancers such as basal cell carcinoma, malignant melanoma, Kaposi sarcoma, angiosarcoma, and rarely there are some secondary deposits from bladder, gut, and skin are reported. Histological subtypes as per 2020 WHO classification can be divided into three groups: HPV independent, HPV associated, and other types. Classic type is the most common one. Incidence is around 45 to 75%, which is HPV independent. And other subtypes such as pseudo-hypoplastic, pseudo-glandular, verrucous, cuniculatum, papillary, sarcomatoid are HPV independent, and HPV associated subtypes such as basaloid, warty, clear cell, lymphoepithelioma-like, and mixed subtypes. And other subtypes such as squamous cell carcinoma not otherwise specified, adenosquamous, and mucoepidermoid subtypes. Regarding the pathogenesis, so it has a stepwise progression. Normal penile epithelium undergoes HPV independent or dependent pathways and forms the pre-malignant lesions such as intraepithelial neoplasia. And then it progressed to early carcinoma, and then with the lymphovascular invasion, locoregional spread, and distant metastasis, it progressed to advanced malignancy. Regarding the penile intraepithelial neoplasia, that is considered the precursor lesion of squamous cell carcinoma. This term is now commonly used, but there are some other clinical morphological terms related to this. Erythroplasia of Poiret. This is termed for red patches in the glands, mucosal surface of the glands and inner prepuce. And the Bowen disease is used for the lesions which are flat lesions occurring in the keratinized epithelium of the penis. And the Bovonoid papillosis, which forms warty papules in the skin, and it commonly associated with HPV infection. And classification, WHO classification of the penile intraepithelial neoplasia is divided into HPV independent and HPV associated variants. HPV independence is differentiated penile intraepithelial neoplasia, and HPV-associated types, common patterns such as basaloid, warty, and mixed types, and other types such as pagetoid, clear cell, and spindle cell histology. Risk of progression to squamous cell carcinoma is from 2% to 33% in penile intraepithelial neoplasia. Before I move on to penile intraepithelial neoplasia clinical presentation and management, I will have a short account on lichen sclerosis, which has clinical significance in penile cancer, which is a chronic inflammatory skin disease of unknown etiology. It often leads to phimosis, making examination under the foreskin difficult, and also it promotes chronic inflammation due to the stasis of smegma under the foreskin. It is present in 28 to 50% of all penile cancers, and also often present in penile intraepithelial neoplasia, which accounts for 40% of cases. And it's now recognized as a risk factor in itself for penile intraepithelial neoplasia. Management depends on the location and the severity of the disease. Milder forms of lichen sclerosis can be managed with topical steroids, but more advanced ones need circumcision. Again, back to penile intraepithelial neoplasia, it presents in various modes. It can present from moist red patches to dry scaly patches, can be painful or painless, and can present with associated pruritus, contact bleeding, or crusting. And due to the inflammation, they can also present with male dyspareunia. Usually, it occurs in the prepuce 45% of the time, and 38% in the glans, and rarely in shaft. Diagnosis is usually a clinical diagnosis, but dermatologists may use dermoscopy to assess the indeterminate lesions. And to confirm the diagnosis, we can do the biopsy, whether it can be an incisional biopsy, or if it's small lesions, we can go for an excision of the lesion and histological examination. Management can be divided into invasive and non-invasive method. Invasive methods, surgery surgical procedures such as circumcision, glands resurfacing, and most micrographic surgery, and cryotherapy, laser ablation, and photodynamic therapy. Non-invasive methods are topical chemotherapy with 5-fluorouracil and imiquimod. And when we decide on the management plan, we should consider about the circumcision status, site and focality, histology, and patient's comorbidities. Mainstay of treatment in balanoperpetual disease is the circumcision. After circumcision, the glands mucosa keratinized over a period of 3 to 6 months, and any residual intraepithelial neoplasia or lichen sclerosis may resolve. And there is a strong argument for prophylactic circumcision in all cases, including the immunocompromised patient with or without a history of HPV or lichen sclerosis prior to starting any other mode of treatment. Glans resurfacing, it is a preferred option for glandular intraepithelial neoplasia, where can be upfront or after a failure of topical treatment. It can be partial or total resurfacing. Performing a circumcision during the glans resurfacing allows for optimal oncological outcomes and future surveillance. Total glans resurfacing is usually curative for intraepithelial neoplasia if the urethral margins are clear. However, 28% will require further surgery for positive surgical margins or understaging. Partial glans resurfacing carries a higher risk of local recurrence, and extension of intraepithelial neoplasia down the urethra or positive surgical margins are the indications for early revision surgery, such as distal urethrectomy or glansectomy. So technique-wise, for a total glans resurfacing, the glans region is divided into 4 quadrants from meatus to corona, and then the mucosa is dissected off from the corpus spongiosum, and the defect and is grafted with split thickness skin graft. We can also combine deep biopsy from corpus spongiosum to assess for any deep involvement. And then topical chemotherapy. This also can be used as a first-line therapy for smaller lesions. However, the failure rates can be high, so it needs close monitoring, and patient should be counseled for multimodal forms of treatment. And the discontinuation due to side effects is higher, which is of 12% of cases. And insufficient response and recurrence may signify underlying invasive disease, so should not be repeated if the first-line treatment fails. So two topical chemotherapy agents are used: 5-fluorouracil and imiquimod. 5-fluorouracil is a thymidylate synthase inhibitor that disrupts the DNA replication. It is applied as 5% cream daily for 4 to 6 weeks, and the response is assessed. Response rates are around 48 to 74%. However, the recurrence is seen in 11% of cases. Side effects such as erythema, erosions, and crusting may result in discontinuation of the treatment. And the imiquimod is an immune response modifier that acts through the toll-like receptor 7 to activate cytokines to initiate a local inflammatory reaction. It is used as 3 times per week for 12 weeks regime. Response rates are around 40 to 100%, but however, the recurrence rate are higher than the 5-fluorouracil at 20%. It also has a similar side effects to 5-fluorouracil. There are other options for intraepithelial neoplasia, such as laser ablation, NDAC or carbon dioxide lasers are used, and total response rates are of 52 to 100%. So disadvantages of using it, the higher recurrence rate up to 48%, and also the complications such as altered pineal sensitivity. And cryotherapy can also be used, which uses liquid nitrogen, usually it's used as a component of multimodal therapy. And disadvantages are it is only successful in 14% when used alone. So it should be combined with other top modalities. And the risk of stenosis in cases of perimeatal disease. My references are from EAU guidelines and BJUI. Thank you.
Thank you very much, Sanjeev, for comprehensive presentation. I would like to ask a few questions from you, and then we'll go to experts for any other questions or any explanations. So there is a patient, 65 years old, gentleman coming to your clinic with discharging small lump in his glans, penis. So what are the things that you would consider in the history taking and examination?
So in the history taking, sir, I will ask about his age and comorbidities. And then I will go to assess his presenting complaint, the lump, the duration, and the type of discharge, and any past history of similar lesions, or any past history of HPV infection. And also I will take history from I will assess whether he has undergone circumcision earlier, and then I will assess for any any previous treatments given for that lesion, and then I will proceed to examine the patients.
Any other things in the history?
I can ask about the risk factors such as smoking and any ultraviolet exposure, dry exposure, and past history of recurrent infection in the prepuce and the glans region.
Yes, and then sexual history and what age first sexual contact and all those things. Yeah, examination.
In the examination, I will examine the external genitalia first, sir, and then if it doesn't have a phimosis and the foreskin is retractable, I'll examine the glands and the lesions, and it's the size of the lesion and the morphological appearance and the extent of the lesion and the focality, whether it's a unifocal lesion or a multiple lesions. And I can palpate the lesion to assess the depth of involvement. And then I will examine the other regions of the external genitalia and proceed to do the inguinal lymph node examination. With that, I will be able to come to a diagnosis.
Okay. In your presentation, you mentioned biopsy techniques. You mentioned two, I think, excisional biopsy and incisional biopsy. Any other type of biopsy?
Srinath and me, normal Srinath.
We can do the punch biopsy, sir.
Yeah. So in which scenarios you would select 3 different biopsies?
If it is a smaller lesion, I can excise the full lesion and do the examination, histological examinations. If it is involving a large area, then I will go for incisional biopsy or punch biopsy, and then with the histological assessment, I can decide the further management.
Larger lesion, I think you better not to do these punch biopsy. I think. Is that okay with Dr. Srinath? I think a punch biopsy is for just superficial like lesions, isn't it?
Yes.
Yeah. And the other thing is, yeah, you mentioned about circumcision. Anything different in this situation in circumcision compared to your normal circumcision for other conditions?
I will try to include the lesion as much as possible in the circumcision while doing the circumcision, sir. So not to leave behind anything with the preputial skin mucosa.
So you should include all the inner prepuce.
Yes.
That is called radical circumcision, not as normal circumcision. So you should go remove all the inner preputial skin. The other thing I want to ask is, how do you advise your patient to apply the 5-fluorouracil or imiquimod? What are the instructions that you would give to the patient?
So I can ask them to apply it for 12 hours per day, sir, to keep it for 12 hours at least.
Anything else?
I don't know, sir.
They can apply their fingertips, thin layer onto the lesion and leave it for 12 hours daily or every other day with 4 to 6 weeks. So there are different regimes.
Okay.
And then they have to wash their hands immediately. And they have to use barrier methods for intercourse, like using condoms.
Okay, sir.
And then warn them that there will be intense reactions such as erythema, erosions, and those crust formation.
Okay, sir.
Yeah, and if there is anything like that, exudation and erythema, you can apply soft paraffin on it. So in the exam, the examiners might ask those things. So in your slides, the last few slides, the management aspect, I think you better go in more details.
Okay.
Okay. Anything to be added, Dr. Yasiru and Srinath?
Well, you basically asked all the questions that I was planning to ask. Anyway, yes, I think the way of administering 5FPU, I think you should have an idea. I think, Nishanta, you covered everything. That's it. Actually, I have nothing much to say. The discontinuation rate is very high. Sometimes they use it along with a steroid cream as well as the paraffin, as you correctly said. Some people, stop it for a while, give the steroid cream, and then restart it, or sometimes they are given simultaneously. The discontinuation rate is high because of these effects, the local effect. Other than that, I think, Sanjeev, you basically covered everything. I don't have much to say. That's the 5FU. I think, Nishanth, you basically covered everything as well.
Okay, then shall we move to the next question?
Yeah. I agree. Just one thing to add. During the history, maybe better to ask about any previous radiation to the pelvis. And I think in the exams, it's mostly they look for the advice regarding the application of IFU and everything.
Yeah. Good evening, all of you. I'm Dr. Prasanna. I'm going to discuss about diagnosis, staging, and treatment of invasive penile cancer. As most of the things are discussed by the Dr. Chanjeev, I want to apologize because there are some same slides are coming. So again, introduction as we already discussed, and risk factors and the pathology wise, he discussed mainly 95% of squamous cell carcinoma and 5% there are other types, mainly BCC, basal cell carcinoma, malignant melanoma, sarcoma, and metastasis from other organs, mainly prostate, bladder, and the colorectal regions. And location already discussed. And when the initial evaluation again discussed like a history in the symptoms and the duration, risk factors, complication, and previous surgery or previous chemoradiotherapy, and the quality of life, erection, and sexual activity, and psychological impact. Then examination wise, mainly the palpation of we have to retract the prepuce and palpate the glands for any palpable nodular lesions. Then we have to palpate the corpora cavernosum and the bilateral inguinal nodes and pelvic nodes if palpable. Then when we look at the sensitivity for the palpation for the corpora cavernosum, it's around 86% and specificity 100%. For the lymph node, it's around 90% sensitive and 20% specificity. And diagnosis mainly by the tissue biopsy. So incision biopsy, excision biopsy, and punch biopsy already discussed. And FNAC inguinal nodes are clinically positive. Clinical means either we can do the palpation or the ultrasonically. Then staging as TNM stage. So it's a carcinoma in situ, and TA is the non-invasive carcinoma, and T1 mainly the subepithelial. The carcinoma is invaded into the subepithelial tissue. T2 mainly the spongiosum. It can be either invasion into the urethra or not. And T3 is corpora cavernosum. So the corporal cavernosal body is the blood containing, so it is come as T3. And T4 is tumor invade into the adjacent structure. It can be skin, scrotum, prostate, those things. And again, regional lymph nodes. N1 is the palpable mobile unilateral nodes, and N2 is the palpable mobile multiple or bilateral inguinal nodes, and N3 is the fixed inguinal nodes, so pelvic lymph nodes, or distant nodes. And again, distant metastasis, M node or M1. Then the grading initially is the broadest grading. It's now it's replaced by the WHO grading. There are either 3-tier or 4-tier grading system. It consists of well differentiated, mild differentiated, moderately differentiated, and poorly differentiated gradings are available. And when we look at the imaging, we are doing the imaging for the imaging of primary, imaging of metastatic lymphadenopathy, and imaging of distant metastasis. So most of the time we can, our clinical examination is good enough to go ahead with the imaging for primary. No need for imaging for primary. But in some situation, if it clinically indicated, then we can think about the imaging of primary. This can be done by MRI. So primary tumor staging by palpation, and often sometimes it's under staging or sometimes over staging. It's around 10 to 16% it's under stage. So modality of choice is MRI. So it gives the prognostication. So before treatment plan, you can tell the patients regarding prognostication. Then you can get the treatment plan, mainly the organ preserving, penile preserving surgeries. Then you can go ahead with the MRI and decide of surgery. It can complement the initial clinical evaluation and enhance the accuracy of preoperative staging. MRI imaging gives the penile anatomy in detail, including its relationship to the surrounding structure, and you can identify the invasion of corpora cavernosa, spongiosum, urethra, and the prostate. So it gives more clinical detailed evaluation. But if the MRI is not available, then we can think about the penile ultrasound or CT, contrast CT. Again, in the MRI, you can do the artificially erected penis by giving the PGE1 prostaglandins. So imaging for the distant metastasis, MRI or CT fusion PET CT is the highest sensitivity, but usually routinely we can go ahead with the contrast enhanced CT with the chest, abdomen, pelvis to identify the distant metastasis. I'm not much talking about this imaging of metastatic lymphadenopathy because our next presenter is going to discuss the lymph node imaging. Then when we come to the treatment of superficial non-invasive disease, that means already in situ discussed, again TA disease, again it's a non-invasive carcinoma, already discussed regarding the topical therapy, 5-fluorouracil and imiquimod. The additional thing is that if there's recurrence with the topical therapy, then no point of reapplication of this. So we can't repeat it. So we have to think about the other mode of treatment. Then ablation, laser ablation, already NDJEC, CO2 laser, organ, or the KTP lasers we can use, but the recurrence rates are high. The advantage of the limitation of CO2 laser is the very minimal penetration, is around 1 millimeter penetration, but ND-JAK laser is good penetration up to 6 millimeter. But main disadvantage of ND-JAK is there's a charring effect. It causes we can't get the repeat sampling to evaluate the success. Then surgery, we can do the wide local excision or most micrographic surgery and glans resurfacing. So already wide local excision discussed. The now accepted this tumor-free margin or wide local negative margin is more than 1 millimeter is accepted. But studies have shown that surgical margins of 5 to 10 millimeter are safe as enough as 2 centimeter margin. But when we look at the 10 to 28 millimeter surgical margins provide adequate tumor control. Then when we look at the treatment of invasive disease confined to the glands, that means T1, T2 diseases. So stage 1 disease. So foreskin tumors are treated by radical circumcision, already discussed. And for glandular and coronal lesions, wide local excision, partial glandsectomy or total glandsectomy, then with the adequate reconstruction. So we can do the reconstruction either split thickness skin graft or buccal mucosal graft. Patients with tumors confined to the glands and prepuce that are not eligible for wide local excision or glands resurfacing are good candidate for glandsectomy. Patient with poor vascular function, diabetes, immunosuppression, or previous radiation to the groin area are less suitable for graft applications due to higher failure rates. Graft failure rates are high, which should be discussed with the patient when making the decision between graft application for primary closure. So amputative and partial amputative surgery is reserved for more advanced disease. There's no comparative evidence between partial penectomy and glanectomy for T1, T2 lesions. However, most case series report similar recurrence-free rate between penile spine surgery and the amputative surgery. So main thing is that this is a rare disease, so there's no randomized trials. So only this case series and the are available. Then when we look at the treatment choice, again, continue with the invasive disease T1, T2, treatment choice depend on the tumor size, histology, stage and grade, and localization and patient preference, width of the surgical margins. 5 mm versus 1 mm local recurrence rate only increased considerably when the distance from tumor to margin was less than 1 mm. So now accepted margin more than 1 mm is acceptable. For bulky or higher grade lesions where local recurrence may have an impact on survival, adoption of a wider margin or partial penectomy may be prudent and should be discussed with the patient. When we look at the micrographic surgery, that means Mohs surgery is a surgical technique in which tissue is excised and processed with the histologically immediately in the real time to give a complete circumferential and depth margin. It aims at maximal organ preservation by adoption margin guided excision. So just we have to cut and same time the real time we have to examine with the microscope. Then radiotherapy, again, it's an organ preserving approach with a good result. So we can use as a EBR, external beam radiotherapy or brachytherapy. So mainly for the T1 or T2 lesions with the low grades, we can use it, and less than 4 centimeter and distal tumors are preferable. Again, for the external beam radiotherapy alone or EBRT with the chemotherapy, we can use treatment option after circumcision. Again, we can consider prophylactic lymph node radiation if selecting EBRT. So patients who underwent penectomy had higher 5-year local control rates and 5-year disease-free survival rates. However, overall survival is same. And when we look at the brachytherapy, there are 2 modes of brachytherapies there. We can take the either short or long rate. And when we look at the locally advanced disease, that means the stage 3 disease, it's a T3, T4 disease, resectable diseases, clinically T2 disease where there's doubt of corporal or tunica albuginea invasion, rather than continuing the dissection over buccal fascia to perform glanectomy combined with a distal corporectomy, dissection superficial to the tunica albuginea can be adapted after dividing the neurovascular bundle. Preoperative MRI or ultrasound can assist in surgical planning. For clinically T3 patients with obvious involvement of corpora cavernosa, partial amputation is standard management. Patient can be offered reconstructive options such as urethral centralization and the neo-glands formation with the use of appropriate graft. Radical amputation and diversion of urination with a perineal urethrostomy is reserved for those patients whom resection with a safe margin would result in inability to avoid standing upright or without wetting the scrotum. Radiotherapy for locally advanced penile lesions should be undertaken with a concurrent chemotherapy. Then those are for the resectable T3, T4 disease, and for non-resectable disease, if it is non-resectable disease, induction chemotherapy, we can offer the induction chemo, then again reassess the patients whether either patient is getting downstage the disease, and then we can think about the surgical resection among responding people, even among men with advanced penile cancer. In case of not obtaining a response sufficient for resection, palliative chemoradiotherapy is an option. So again, it's a summary of surgical treatment. Our main stage 1 disease, mainly our local therapy and the glands resurfacing or wide local excision or other mode of like a laser or cryotherapy. And stage 2 diseases, mainly we can again glanectomy and glands resurfacing. And we can think about the other mode of partial penectomy. And T3, T4 disease, we have to again classify into either resectable or non-resectable. Then we can think of the treatment. So when we consider the recurrence, so recurrence mainly occurs within the 5 years. Even though within 5 years, most of the recurrence are within 2 years. So follow-up mainly looking for the up to 5-year periods. So when we look at the recurrence, it can be recurrence to a local recurrence or recurrence to a lymph nodes or distant recurrence. So local recurrence should be treated according to the stage of the recurrence. So again, we have to restage the disease and we have to think of the treatment. Local recurrence after organ sparing surgery, a second organ sparing procedure can be performed if there is no corpus cavernosal invasion. For large or high stage recurrence, partial or total amputation is required. Unless unresectable or concurrent with nodal disease, nodal or distant metastatic recurrence. Inguinal recurrence, again, lymphadenectomy if not done before, radiotherapy if not given, and chemotherapy, if radiotherapy given, then we can think about the chemotherapy. And when I'm not much talking of metastatic disease because our next presenter will discuss the metastatic disease, but main thing is the metastatic pineal cancer. We have to give the systemic chemotherapy, then restage the disease. If it is responding, then we can think about the surgery. If not responding, it's a palliative. Thank you.
Thank you, Prasanna, for a nice presentation. I have some few questions. The previous patient, who was presented with a lump in his glands, has underwent incision biopsy. So what are the features that you would look for in the histology report?
Yes. So in the histology report, size of the lesion and where's the location and the mark. We took the incision biopsy. So location where's the located tumor and the histological type. Main important thing is whether it is a good prognostic histology type or bad prognostic one. Then the invasion, whether it is the neurovascular invasion, lipovascular invasions are there or not. These are the things I will look in the histology.
So what are the bad prognostic ones?
Mainly the sarcomatoid variant is the bad prognostic, and OT and the verrucous are good prognostic ones.
Sarcomatoid and basaloid type.
Basaloid, yes.
Yeah. Oh, okay. In tumor staging, there is a T1 category as divided into two. Why? Why is that?
Yeah,
What is
it's
the
a
difference?
it's a neurovascular invasions are present. It's a absent is a TA and if it is present is TB. So,
Is it only neurovascular invasion?
neurovascular and lymphatic. I'm not sure.
It's lymphovascular invasion, perineural invasion, or higher grade.
Yeah. Yes.
Isn't it?
Yes.
So why they have divided into two? What is the difference?
If it is TA disease, we can think about the topical therapy or the things. But if it is higher grade or the TB disease, then we have to think about the most aggressive treatment like surgical options.
Yeah, because the T1A disease has a lower chance of lymph nodes positivity in the inguinal lymph node basing. So less than, I think, 6% or 5 or 6%. I believe T1B it is very high, about 25% or so. So the management is totally different.
Yes.
For T1A, we can go for surveillance without doing inguinal lymph node staging. But T1B, we need inguinal lymph node staging. So even if T1A disease, in what circumstance would you consider inguinal staging rather than surveillance?
I'm not sure, sir. It is
So, for
proximal.
example, if the patients, so these patients need intense surveillance. If the patient is not compliant enough, or if he is from far away, then maybe consider doing some inguinal lymph node staging, isn't it?
Yes.
The other one is there is an intermediate grade T1 disease with grade 2. So, what are the options for that?
Yeah, we can T1 disease grade 2, sir. We can go ahead with the topical treatment or non-surgical treatment. We can go, and the other thing is the surgery. But if it is higher grade, then those topical treatment and those things are out.
I think localized treatment is same, either the glance resurfacing, laser, radiotherapy, all those things. But the inguinal lymph node staging, either surveillance or staging, you can discuss with the patients about the advantages and disadvantages, and then go for select whatever the options. Anything to be added, Dr. Srinath and Yasin?
Prasanna, you have a 65-year-old patient with a fungating mass in the glands. How would you
Yes.
proceed?
So with this detailed history and examination, sir, I would as a fungating mass, I would prefer to go with the incisional biopsy. And
Is it a
with
must?
the
Is it a must that you need to have an incisional biopsy?
yes, before going for the organ preserving or the penectomy, sir, partial penectomy, give the prognostication and the type of lesion and the histological grading and subtypes. I think we would go ahead with the biopsy, sir.
Not a hard and fast rule. If it's clearly pointing towards a malignancy, you can straight away go for a local resection. So what's the margin? You spoke about the margin. So you are basically having a fungating lesion in the penis. Okay, we'll forget about the resection first. What sort of imaging would you do?
Yeah, I will palpate the inguinal nodes, sir. If inguinal nodes are non-palpable, then I will go ahead with the ultrasound of the bilateral groin region. And if there's
Okay.
if the bilateral
for the local staging.
Yeah, for the local staging, sir, my clinical, if it is T3 disease, that means the copper carnosa involvement, then no need for the any local imaging. But if it's a superficial disease and I'm suspecting of T1, T2 diseases, then I would go ahead with either ultrasound or the MRI. MRI is available.
What are the two main things that you would like to see in an MRI?
Yeah, if there's any corpora carnosal involvement or the
And?
spongiosum involvement and the urethra.
And? There could be skip lesions.
Yes.
Skip lesions, right?
Okay, sir.
Okay, so okay, how do you do a partial penectomy?
Yeah, I will cover this tumor area with the finger gloves or the condom, and then I will mark the incision site. It's around from the 1 centimeter from the tumor, distal to the tumor, proximal to the tumor, and I will cut the skin and I will deglove the penis, and I will separately cut the neurovascular bundles, and then we can cut the corporal carnosum and spongiosum, either the fish mouth fashion or the direct cut, and I will centralize the urethra, and I will close the tunica albuginea and bug fascia, and I will use the, if it is skin flap is adequate, then I will close the skin, or otherwise I will think about the put the adequate graft using the either split thickness skin graft or the buccal mucosa, and I will think about the reconstruction of the glands if necessary.
Will you do the lymph node treatment at the same time?
Yes, sir. If it is clinically not negative disease, then we will think about the sentinel lymph node biopsy. Or if it is clinically positive, then we can next session I will think about this inguinal lymph adenectomy.
In an exam, I think it's best to say you would do it in a separate situation, isn't it, Nishanta? What do you think about it?
Yes.
For the sentinel lymph node biopsy, sir?
Sentinel lymph node biopsy also, they say that it's done separately. There's not going to be a problem. We think that the what do you mean, the cancer should be there. There's no such thing like that, because we give I'll discuss that after the next presentation as to how the sentinel lymph node biopsy is done. So it's not essentially given peritumoral, as is the case in probably breast cancer, etc. But it's not so for penile cancer. So it's not a must that the primary is there. So normally what happens is the primary is treated, and then the patient here has a sentinel lymph node biopsy using the radionuclide after the primary section, as far as I can remember. The other thing, any papers to suggest the margins that you are doing the right thing? You said 1 millimeter, you said 5 millimeters. So what is right at the end of the day?
Yes, sir. According to the EAU guideline, is 10 millimeter margin is adequate. But 10 to 20 millimeter margin gives a good tumor control.
Yes, of course. Yeah. But the thing is, there are two studies now. There is a chap called Minas who says 5 millimeters is enough. And there's another one called Sri et al. Who says 1 millimeters is enough. So for more proximal lesions, they are now going away from the trend of total penectomies. So very rarely is total penectomies, of course, because probably the patients turn up quite early, probably. That also is not really the case in penile cancers, but the rate of total penectomies is quite diminished because of the fact of the two reasons. One is that the margins that need to be taken are less, and also the fact that the local recurrence does not translate to poor prognosis as such. So therefore, there's a lot of scope towards penile preserving surgery. Anything, Nishant, you want to add to this?
I have some question. You mentioned about MRI
Yes.
staging for T1 and T2 disease. Is it? I don't know whether I have got it wrong or.
No, sir. Actually, if we are
when do
going
you
to
use MRI?
Yeah, if we are going to differentiate between T1 and T2, it's not useful MRI.
Yes.
But mainly our aim of thing is that T3. We are thinking of doing the penile preserving surgery with the suspecting T3 disease, then MRI is useful, sir.
Yeah. What about
Mainly
ultrasound?
We can use if it is MRI not available, then we can use the ultrasound penis, sir. And it's I can't remember the sensitivity. I think it's around 60 to 80% sensitive enough to identify the T3 lesions.
I think it's approaching 100%, I think.
Yes, there are centers in UK where they use ultrasound exclusively. And of course, they should have a good uroradiologist who does it. So it's definitely operator dependent. You use at least, as far as I can remember, it's more than 13 hertz, megahertz or something like that.
7.5 to 10 megahertz.
Yes, but for PIN is higher is better. That is basically for testis and everything. So they say that the uroradiologist here basically said that for PIN is about, they have probes that approach more than 12, which basically gives a very high sensitivity. So ultrasound definitely has a place.
Prasanna, what is the place of frozen section in localized treatment?
Yes, sir. We have to, if we are doing the white local action or the things, partial penectomy, and we are more concerned of the length of the penis, frozen section is important, and we can use.
Yeah, when going for penile preserving approaches.
Yeah, yes.
You mentioned partial penectomy. Any complications after partial penectomy?
Yeah, as the usual complication with the mainly this bleeding infection. Other than that, they will develop this erectile dysfunction, sexual unsatisfaction, sir, and sometimes they can develop this like this unusual sensation, those things, sir. I don't remember.
They would get the splitting of their stream. So there is no natural meatus. So splitting of stream, and then later on they might get urethral stenosis, meatal stenosis. So those are the things that I would like to ask.
Yasiru,
do you have any?
Yeah.
Sorry, Sina, go ahead.
Yes, I wanted to ask Yasiru his experience on radiotherapy.
Yeah.
Yeah, it's for the T1 and T2, we can of course give radiotherapy, but the penile cancer in current days, it's mainly a surgeon's disease. Very rarely we see the radiotherapy being used, especially if there's like a contraindication for the surgery, like pulmonary hypertension or like anesthetic, not fit for anesthesia, we consider for the radical approach. The brachytherapy is more rare these days because it's like it needs some good centers with clinical experience. So it's almost like not used in the UK and all. The external beam radiotherapy, we have to give a traditional squamous cell dose of more than 60 gray of equivalent dose, and it is usually the primary lesion we are treating. The elective nodes irradiation is a bit of like an individualized approach because we expect the lymph node staging with the sentinel lymph nodes, or because the ultrasound is inadequate for the lymph node staging. So usually for the exam purposes and all, I think if the patient is not fit enough for the surgery, the radiotherapy is used for the organ preservation approach, especially with the new surgical techniques. The radiotherapy is much less used now.
What about neoadjuvant prior to total penectomy? And the feasibility as well.
Yeah, the neoadjuvant chemotherapy, the approach is a bit different in the UK and the US. The US, they use a tip chemotherapy, the ifosfamide-based bit of a toxic chemotherapy regime. It is for the locally advanced, in the UK, they use a bit of less toxic chemotherapy, paclitaxel and carboplatin. But when you see the literature, it's there's less evidence, but the evidence is for the TIP, the cisplatin, paclitaxel, and the ifosfamide-based chemotherapy, which is used for the neoadjuvant. For the locally advanced before the surgery, we use that one.
Nishant, do you refer patients to oncologists prior to total pinectomy if the surgery is total pinectomy? I have to be very
No.
frank because I basically when we were
So I
SRs,
talk to my oncologist when actually when the fixed lymph nodes and those things when I need help, but
Yeah.
not for the primary lesions so far.
Yeah.
Prasanna, we talk about radiotherapy. Any complications associated with?
Yeah, with the radiotherapy, they can develop mainly the urethral stricture and the urethral fistula. Those things they can develop. So other than that, the local irritation and erythema, those things they can develop. The urethral side they can develop.
Yeah, and the glands necrosis.
Yeah, necrosis.
Yeah, we'll move to the next presentation, I think. Dinendra Madhushankar, management of penile cancer with non-palpable and palpable lymph nodes. Dinendra, over to you.
Hello. I'm going to discuss about the management of penile cancer with non-palpable and the palpable lymph nodes. And in penile cancer, it's a disease which metastasizes mainly through the lymphatic system, and it follows a gradual progression over the inguinal lymph nodes, pelvic lymph nodes, and to the distant metastasis. And in the staging purpose, the presence and the extent of the lymph node mets is the main prognostic factor in view of the survival of penile carcinoma. And depending on the lymph node status, the cancer-specific survival varies. If it is a node disease, it is 95%. In one disease, 80%. In two disease, 65%. And in three diseases, it declines further to 35%. So as it's shown, it is very important to identify the lymph node stage in the treatment of penile carcinoma. And the methods to identify these micrometastasis is very, and in our traditional TNM staging, it gives that lymph node status can be assessed clinically by palpable and whether they are mobile or fixed. And then further it can be classified after resection by the pathological lymph node status as well. And when we move on to clinically node negative disease, even though clinical nodes are negative, still there's a risk of 25% occult metastasis staging is warranted. So how do we assess the lymph nodes? We can use non-surgical methods, CT, FDG PETs, but all these methods have their own drawbacks. CT, it is not good in diagnosing micrometastasis, and FDG PET is also cannot detect less than 10 millimeter lymph node. It's not helpful. So the imaging wise, it's limited value in the initial assessment of the clinically node disease. So then there's a place for surgical staging of lymph nodes, inguinal lymph nodes. And this is further stratified by these risk categories, depending on the patient's T stage and the grade of differentiation, perineural innervation of the primary tumor. So depending on this risk, in terms of high-risk tumors, where the tumors which are warranted specifically surgical staging. And as Nishant said, intermediate risk tumors, there's place for surgical staging, but it is depending on the patient's wishes as well. And how do we do surgical staging of the lymph nodes? By definition, radical inguinal lymph node dissection is the one which will give the accurate surgical idea about the lymph nodes. But it is not helpful because it has more complications and it is over-treatment of the disease. So it has modified inguinal lymph node dissections where we can reduce the complications and same time we can get the lymph node yield. but still those two methods still causes a lot of complications, and most patients sometimes it's like over treatment. So with the time it has evolved that the concept of dynamic sentinel lymph node biopsy. And when we opted a patient for dynamic sentinel lymph node biopsy, always we need to do an ultrasound scan of the groin. Thereby we can identify lymph nodes and we can do ultrasound guided biopsy, and we can reduce the need of dynamic sentinel lymph node biopsy about by 10%. So about dynamic sentinel lymph node biopsy, a sentinel lymph node is a lymph node which is the first draining lymph node from a direct pathway of the tumor. And if theoretically, if the sentinel lymph node is negative, we can say that probably the absence of the tumor spread is there, and the corresponding lymph node basin is clear of tumor. So with that concept, we use sentinel lymph node biopsy, where we use technetium-99 nanocolloid along with isosulfan blue dyes as a combination to increase the sensitivity, and we inject either peritumoral or to the glands, and then we trace it using the gamma scan as well as the color of the isosulfan blue dyes, and then we harvest the lymph nodes specifically and check for the presence of the metastasis. And this technique need expertise, technical challenge, and so with a good hand, it gives a sensitivity of 92 to 96%. And same time, it has less complication rates compared with the inguinal lymph node dissections, about 6 to 14%. And this dynamic sentinel lymph node biopsy can improve 5-year survival as well. And then we move on to clinically node positive disease. When we examine if there are clinical nodes positive, the risk of underlying malignancy, underlying metastasis is about 45 to 80%. And this can be confirmed by image-guided biopsy, either ultrasound-guided or CT-guided biopsy. And in this scenario, pelvic lymph node assessment also must. We can use different imaging modalities. And CT we commonly use, but it has less sensitivity, about 20 to 38%. But MRI gives more sensitivity, and FDG PET CT would be a good investigation with a sensitivity of 91% and a specificity of 100%. And in that scenario, we have to always exclude distal metastasis by doing CCT, chest and the abdomen. So when we come to the management of nodal disease, the presence of the regional lymph nodes and the extent of the lymph node involvement, as we discussed, is the most important prognostic factor. And if the lymph node involvement is confined to the regional lymph nodes, by giving radical lymph node dissection, we can achieve a cure. And if the disease is more advanced beyond that, then the patient needs a combination of multimodal treatment. We will discuss later. It is using of chemotherapy, radiotherapy, and a surgery. So when we discuss about clinically N1 and N2 disease, the mainstay of treatment is radical inguinal lymph node dissection, which is the standard of care. And who are the people indicated are the patients who are having clinically N1 N2 disease, and patients, although they have N node disease, but if the sentinel lymph node biopsy is positive, still they warrant radical inguinal lymph node dissection. Before moving to surgical part, bit about inguinal lymph node anatomy. Inguinal lymph nodes are arranged into two parts, like superficial and deep lymph nodes group. And superficial group, these are confined to the area which is confined by triangle superficially inguinal ligament, medially sartorius, and the adductor longus muscles laterally. And it contains about 10 lymph nodes in the superficial group, and they drain into the deep groups and they connect to the pelvic lymph nodes as well. And the Dressler, who discuss more about these things, it describes 5 regions of lymph nodes which are situated around the sternofemoral junction. And majority of these sentinel lymph node biopsies, this lymph node involvement groups. So radical lymph node dissection is mainly described by the Dressler's description in about 1948, and where he is described the removal of complete superficial and deep inguinal lymph nodes. But though it has good clearance, there are a lot of complications associated with that radical dissection. So with the time, it has modified into modified template lymph node dissection or fascial sparing inguinal lymph node dissection. And comparison of these two techniques, there are no randomized control studies to compare that, but in the modified lymph node dissection group, the 3-year disease-free survival is about 92%, and more interestingly, the complication rate drops to about 29%. And this inguinal lymph node dissection, as we discussed, the radical lymph node dissection described by Dressler's quadrilateral area involved the inguinal ligament, fossa ovalis, sartorius, and the adductor longus. And there they remove all the lymph nodes along with the saphenofemoral vein, and it needs always flap cover, usually sartorius flap cover. And in the modified template lymph node dissection, there it has the mobility is reduced by selectively resecting lymph nodes, which is more medial to the femoral artery, and they preserve the great saphenous vein. And there's no use of flap cover to close the wound. And this fascial sparing lymph node dissection, as described in EUA, it also has same margins of radical lymph node dissection groups, but the differences are the deep fascia involvement is not in fascial sparing part, and the saphenous sparing also there, and they doesn't use sartorius transposition. So the mobility is less. When we offer this surgery of inguinal lymph node dissection for the patient, following primary surgical treatment for the penile cancer, within 6 weeks, early treatment is recommended. And there are trials, this Ciappellini trial, which shows the effects of early versus late inguinal lymph node dissection. The 5-year disease-free survival is 64% in early treatment versus 39% in late treatment. So early lymph node treatment is warranted. And what are the complications of this inguinal lymph node dissection? Although it gives good lymph node control, it has significant complications. It associated with wound infections, skin necrosis, lymphedema, lymphocyte formation, and seroma formation, and all this anesthetic patch involved in the thigh regions, and the complications are more. And how do we avoid these complications? There are some factors which will affect positively as well as negatively in the reduction of mobility following radical inguinal lymph node dissections. The positive factors, they say about linear transverse incision, the saphenous sparing, volume controlled drainage, the fascial sparing surgery, and minimal invasive techniques, this lymphedema prevention methods, and deep venous thrombosis prophylaxis, and prevention of surgical site infections. If we can achieve these things, we can reduce these comorbidities associated with radical lymph node dissection. And the comparison between open lymph node dissection versus minimally invasive approaches are there. This minimally invasive approach are video endoscopic inguinal lymph node dissection, or the short form of WAVE, and the robot-assisted video endoscopic inguinal lymph node dissections. By offering minimal invasive approach, the patients will have less complications, but same time he will have similar oncological outcome. Yet there are no recommendations of offering minimal invasive approach for the patient. And the place of prophylactic pelvic lymph node dissection. When the patient is having positive inguinal lymph nodes, and when there are extracapsular extension and immunoreactivity to P53, lymph node density more than 30%, and primary tumor grade, it is more severe grade, then these patients need prophylactic pelvic lymph node dissection. And when we come to end-stage disease, clinically more bulky and more fixed to the skin under deep structures, this ulcerating, fungating wounds, history and examination, we have to, and always we have to assess we have to biopsy the inguinal mass if the patient is not already diagnosed with a penile carcinoma. And how do we manage this group of patients? Neoadjuvant chemotherapy has a main role in treating this N3 disease because it gives a good tumor control. It shows that radiological response can be achieved 53%, and it gives pathological complete response in 12%. It can be seen. And there are certain chemotherapy regimes are there in the practice. They use this TIP regime, which include paclitaxel, ifosfamide, and cisplatin, and this TPF regime, docetaxel, cisplatin, and 5-fluorouracil. So in both arms, it gives good chemotherapy control of the disease. And by offering neoadjuvant chemotherapy, it also gives the advantage by early treatment of systemic disease, and we can downsize the inguinal lymph node. Thereby, we can reduce the surgical margins and the surgical mobility of the patient. And earlier, we thought surgery as the initial treatment, but when the patient is having N3 disease associated with more complications and poor outcome. The overall complication rates about 65 to 77% are there if you offer surgery first. So it is not warranted in N3 disease. So patient selection for consolidative radical inguinopelvic lymphadenopathy after offering neoadjuvant chemotherapy, after consolidating the disease, we can offer radical inguinal lymph node dissection along with pelvic lymphadenopathy. There's a mean 5-year survival of about 56% can be seen according to systemic reviews. And if patients are not suitable for neoadjuvant chemo, there's place for radiation, but it's always non-superior, just to downsize the lesion just to accommodate them for surgery. And there are some trials which assess these outcomes. The IMPACT trial, which is already undergoing, which is UK trial, there the questions they want to assess is the place of neoadjuvant therapy in the treatment of nodal disease, and if so, what are the options like chemotherapy or the chemoradiotherapy? And then does prophylactic pelvic lymph node dissection improve survival? And these questions, they are still, the patient trial is on process, so we can see the results later on, how it benefits to the patients. And about this resection, following neoadjuvant chemotherapy, once the tumor get controlled, after 5 to 8 weeks of completion of chemotherapy, we can offer surgery. There are wide local resection, like for radical lymph node dissection, the margins are similar more or less, but the dissection is dependent about the involvement and the extent of the involvement of the disease. And we have to get a wide excision as an en bloc dissection of the all involved lymph node regions. And definitely it will give us a wide tissue loss, so that can be replaced by the help of the plastic surgical consultations. And then pelvic lymph node dissection also warranted, and if the disease is involved in the pelvic lymph nodes as well. So the summary, the evidence is saying that surgery alone is rarely cure the patients with N3 disease. So neoadjuvant treatments are warranted. And even if it is technically feasible, upfront surgery is associated with significant complication because of the complications. And about half of the patients with advanced penile cancer respond to combination of chemotherapy, and the responders that subsequently undergo consolidative inguinal pelvic lymph node dissections have an overall survival chance about 50% at 5 years. And about radiotherapy, the trials are still underway, and they haven't concluded about the radiotherapy as a main treatment for advanced disease, but it can be combined with chemotherapy to get a good outcome. And it is as a palliative treatment when the patients are not suitable for chemotherapy. And now immunotherapy trials also underway, which targets this PD-1 ligand pathways, but still the recommendations are not there. Still the research are ongoing. And about the follow-up of the patients with nodal disease. Patients with node disease, the follow-up is the interval about 3 monthly and for initial 2 years, then annually for 3 to 5 years. We can use clinical examination along with ultrasound. If any suspicious areas, we can do the biopsy. And if the patient had lymph node disease, then follow-up is more stringent. The initial first 2 years is 3 monthly follow-up using ultrasound scan along with CT. And if optional, we can use PET CT as well. And after 3 years, it's 6 monthly interval follow-up should be needed. So this is the management of the nodal disease. The references are from UNNCCN. Thank you, sir.
Thank you very much, Dinendra, for a nice presentation. I think for the discussion, I would like to invite Srinath and Yasiru because they may have more experience and knowledgeable in this regard rather than me. Srinath and Yasiru, over to you.
And Shantanu, okay. I think it was a very nice presentation. He covered everything. He talked about the impact trial, which is a very interesting trial. The results are not out yet. And he talked about the 3 arms that are there in the impact trial. So it's good to look out for the results of that. So, so Dinendra, now, so you have a patient with a penile cancer, mass in the penis and palpable right inguinal lymph node. How would you, investigate and manage the lymph node disease?
So after initial evaluation with history and examination, now it's clinically, the lesion is N1 disease. I suppose it's unilateral, palpable, and mobile lymph nodes are there. So clinically
yes.
N1, yes. Then I'll complete my staging, the local staging with either ultrasound scan or MRI, and systemic staging. MRI would be beneficial to assess the inguinal as well as the pelvic lymph nodes, and CT for the rest of the distal metastasis. And then same time ultrasound guided biopsy from the lesion, inguinal lesion, to confirm whether it's a metastatic lymph nodes or any other pathology.
Yeah.
If it comes as metastatic lymph nodes, then it confirms the patient is having nodal disease. So then I'll again go back to my primary, whether the staging of the primary lesion, whether it's the grade of the lesion, and whether there's any high risk factors of the primary lesion. So concluding primary lesion factors as well as the inguinal lymph node status, I will decide whether this patient need radical inguinal lymph node dissection along with pelvic lymph node dissection as well or not.
Mm-hmm. Okay.
Then first I offer the primary treatment for the penile cancer. Then after about 6 to 8 months time, I'll decide on treating the inguinal lymph node disease. So it is better to reduce the complications. I would offer this modified inguinal lymph node dissection, which is the much more reduction of the surgical margins. So
which side? To which side? To the side where the lymph node is there.
Bilateral. When though it is unilateral lymph node involvement, one thing is to assess the other side, I can do the central lymph node biopsy. Or if the lesion is high risk factors are there, then I can offer bilateral inguinal lymph node dissections.
Bilateral, modified inguinal lymph node dissection.
Bilateral. To the nodal positive side, it's radical lymph node dissection. To the uninvolved side, it's modified inguinal node dissections.
Yeah, that's what that's what I was waiting for. Yes. So the most important thing is that normally speaking, there is no crossover of lymphatics in penile cancer. So therefore, both sides should be dealt separately. That's the most important take-home message I would give with regard to the lymph node management. So, I mean, the right side management is, the left side management is irrespective of the right side. So yes, you have to do an ultrasound groin in everyone, establish the diagnosis that it's a cancer that the lymph node is having, and the right side should be dealt as a lymph node positive disease on the right side. But that doesn't mean that the left side should be left alone. The left side, so this patient should have an inguinal lymph node dissection on the right side, a radical one, and the left side should have either a sentinel lymph node biopsy or a modified inguinal lymph node dissection. So that's the answer that I was waiting for. So when would you do a pelvic lymph node dissection?
When the patient's having N1 or N2 disease, and same time, when the primary tumor shows aggressive features like sarcomatous and basiloid types, as well as the inguinal lymph node shows extracapsular extensions.
Yeah.
And in the imaging, if the pelvic lymph nodes are positive, positive means imaging if there are any pelvic lymph nodes are there.
Correct me if I'm wrong, Nishant. I think it's N2 or extra lymphatic extension. That's what I basically remember.
PN2.
PN2, yes. PN2 or extra lymphatic extension. So that's, again, same applies to the pelvic lymph node dissection. No crossover pelvic lymph node dissection on the ipsilateral, as far as I can remember. So inguinal dissection anyway, that I'm pretty sure, basically there is no crossover. So therefore you have to, deal with those two sides separately. So what, if there's a fixed lymph node, what would you do?
Then it's
Sorry.
clinically.
So inguinal lymphatic spread, there's a crossover, but pelvic lymph node lymphatic, there's no crossover.
So if that is the case, then how should this patient be dealt with then?
So as you said, sir, if it is a right side clinically positive and histologically positive one, we had to go for a radical lymphadenectomy. But at the same time, left side also there's a 30% crossover. So for left side, as you mentioned, we can go for a dynamic, either a dynamic lymph node biopsy, or we had to go for a prophylactic modified lymphadenectomy, inguinal.
Yeah. Okay. Maybe I mixed up.
For pelvic lymph node spread, there's no crossover, sir. So if the lymphatics is, or if the inguinal lymph node, if there's a positive inguinal lymphadenopathy, we can either send for frozen section. If the frozen section shows more than 3 positive, then we have to go for a pelvic lymphadenectomy. Or as you mentioned, we can wait for the histology. Then depending on the histological finding, we can plan for elective delayed pelvic lymphadenectomy. But only one side, sir. No, there's no crossover.
Yeah, Tivika, you are right. Yeah. So yeah, I got it wrong there. So well, the I think the management is basically what I said anyway. So if there's a fixed lymph node, what would you do, Dinan?
So then it comes to N3 disease clinically. So then there's a place for upfront neoadjuvant chemotherapy, and we can assess the by giving there are several regimes are there. The TIF regimes and TF regimes are there. So either triple therapy or dual therapy. Then following chemotherapy, we can reassess the lesion, and depending on the regression, we can plan for a patient need later on surgery. We can plan for radical lymph node dissection after neoadjuvant chemotherapy, sir.
I think I will. That's all I have to say. For FRCS, basically they ask how dynamic sentinel lymph node biopsy is done, like the practical stuff as to when the patient is going to be sent to the nuclear medicine department and what is done there. You basically talked about that in the presentation, so I will not basically talk too much about that. That's it. Anything else you want to add to that?
Just wanted to ask about the indication for the adjuvant chemotherapy.
Yes, sir. They say about N3 disease specifically, they need neoadjuvant chemotherapy, and same time in two disease following radical lymph node dissection, we can go for adjuvant therapy to deal the systemic micromets. Those are the main
Yeah.
areas.
Basically adjuvant for the N2 disease and the any pelvic
Hello.
lymph node positivity. Yes, we can hear you.
Yeah, okay. I think we have done a wonderful session today. I would like to thank Srinath and Yasiru coming today to make our sessions successful. While they have busy schedules, I think we all should thank both of them. Thank you, Srinath and Yasiru, for the presence today and then giving your expert advices. And then I would like to thank the presenters and all the participants and spouse and their sponsors.
Yeah, thanks, Nishanta, and good job to all the presenters. I think they did a good job.
Thank you very much, sir.
Thank you.